So the first person I have the pleasure of introducing is a friend and colleague, Dr. Jeevanandam. His topic is bloodless cardiac surgery, the ultimate art of surgery. I'll give you a very brief bio, and you can read a lot about Dr. J, as we call him affectionately for short, online, but he specializes in the surgical management of heart failure, and he is an expert in high-risk cardiac surgery. This is really the amazing figure every time I read it, but he's performed over 1,500 heart transplants, and he has a special interest in treating patients traditionally considered inoperable. As we all know on this call, many for whom blood transfusion is not an option. He does amazing, amazing work. So he's done reconstruction of damaged hearts in many patients while they're awaiting transplant, enabling them to forgo transplantation. He's successfully performed transplants involving patients who don't fit the standard criteria. Dr. J has rightfully received national attention for his skill in performing, as we said, and why he's here, bloodless, complex cardiac surgery. Obviously, as we all know on this call, those precise surgical techniques, those excellent skills and knowledge to minimize blood loss during the procedure can enable these patients to continue their lives and take the blood transfusion question even out of the mix. He's also a pioneer in the field of mechanical circulatory support, and he has performed first in human device implants, nearly 500 durable LVAD surgeries. He's one of the physicians of the transplant care team that made history in December 2018, amazing story, after performing 2 triple organ transplants within 27 hours, replacing the failing hearts, livers, and kidneys of 2 29-year-old patients. He has performed the heart transplantation operation for all 13 heart, liver, kidney transplants at the U of Chicago here in the United States. That heart transplant program, using data from the most recent report from the US Department of Health and Human Services, is the best in the United States with regard to patient survival and shortest wait list times. In addition, the University of Chicago Medicine program is the only program offering and performing heart transplants and LVADs for patients for whom blood transfusion is not an option. So with that, it is my pleasure and privilege to introduce my friend and colleague, Dr. Jeevanandam. So, Dr. J.
Great, thank you. Thank you very much. So it's my honor, and thank you, Sherry, Christopher, and Nathaniel for allowing me to talk today on bloodless heart surgery, the ultimate art of surgery. We will start with my outline. So I don't have any disclosures, but as I've thought more and more about how this is performed, I realized there are really 4 very important components that will be interspersed during my talk. There's the psychological component, the intellectual component, the spiritual component, and finally the technical. And most surgeons just focus on the technical component of it, but really taking care of patients is much more than just technical. It is really a complete comprehensive combination of your mind to be able to take care of these patients. So the first thing I say is if somebody wants to embark on doing bloodless cardiac surgery, you must have self-reflection. And the self-reflection is that you have to respect other people's beliefs, especially when it may be against your own. I mean, I'm not a Jehovah's Witness patient, but from a spirituality point of view, I do respect everybody's beliefs. And I think that when patients have the faith, and the faith can get them through a challenge, that we have to respect their faith. But from a surgeon's point of view, there's not going to be that many bloodless cardiac surgeons. So how do you have to deal with the team that you're operating with. You have to make sure that they are psychologically stable, make sure that they have philosophical alignment. There are many programs where a patient may go and then all of a sudden the nurse is trying to get them to accept blood. And it's very important, and it's taken years and maybe even decades for our program and to realize that we can take care of these patients. They do well. And so the team becomes much more stable and aligned. The other issue is, in terms of self-reflection, is that mortalities will occur due to bloodless therapy. And is the surgeon ready for it? Is the program ready for it? In the United States, we're all, as Sherry talked about, our transplant data, we're all judged by things like the SRTR, the STS, the US News and World Report. And a a mortality may affect those rankings. And is the institution ready for it? Is the institution accepting of the fact that these patients may have therapy that may hurt them? Our institution accepts it because they also know that the therapy that we give to these patients, they actually do much better than normal cardiac surgery patients. So we don't have that type of risk issue. But if a program is starting or if a program is nascent, they may have these issues. The other real self-reflection for a surgeon is, why are you doing this? I do it because we're providing access to an underserved population. And as my professor always said, if you're not living on the edge, you're taking up too much space. And so you try to do things that differentiate you from society in terms of performing service to society. And I think serving an underserved population is certainly one of those. Interestingly, in our program, once we start taking care of Jehovah's Witness patients or bloodless patients, our blood utilization across all patients has decreased. And we have developed an infrastructure with anesthesia, nursing, perfusion that has actually elevated our results across the board in all cardiac surgery, even if they're not done bloodlessly. You know, for me, there's also a personal component to it. Although we're not Jehovah's Witnesses, my father had open heart surgery, and I remember all night long, you know, we were worried about his bleeding, we were stripping his chest tubes, my mom was freaking out, and it was just kind of like PTSD of just seeing anybody bleed. So I kind of made it my, you know, life mission to figure out how to do patients and not have to worry about bleeding for me, the patient, or their families. So then, if you can kind of pass through all that, then kind of how do you do it? And bloodless cardiac surgery is a challenge because transfusions are critical as a safety net. They're administered in 20 to 60% of cardiac surgery. And if you're not allowed to use that safety net, you often feel like Philippe Petit crossing the World Trade Center without a net on a wire. You know, people always say, well, how do you treat bleeding? Well, you really can't treat bleeding. Once something starts bleeding, and if there is a, you know, a simple surgical source, then you should have taken care of it to begin with, but you can take care of it later. But if somebody develops a bad coagulopathy, that usually means the horse is out of the barn and you're going to be really bad. So the way you treat bleeding is that you prevent it from occurring in the first place. And that is really the secret. And in terms of prevention, we're talking about a selection process of patients, preoperative preparation, and surgical techniques. And then we'll talk about postoperative management. So in terms of a selection challenges, when a patient comes to me, I'm immediately thinking about, you know, if they're a primary operation, that's great. If they're not a primary operation and they're a re-op sternotomy, you know, what is their chest anatomy? How close is the aorta and the right ventricle to the chest wall? Have they had radiation that can cause some scarring? So those are all things that go into my algorithm to see if we can offer this patient surgery. The other issue is acuity. If you have a fresh myocardial infarction or an MI and somebody loads you with Plavix, you know, you often can't operate on them with the Plavix load. And so we defer them, we put in a balloon pump, we pull in some kind of mechanical device to get them through the acute phase so they are a better patient. You know, type A dissections are another big problem. The issue is if there's a type A dissection of Jehovah's Witness that came to my operating, that came to our hospital in the emergency room, we can take care of almost all of them. You know, the problem is what happens if somebody is in Florida or California or Bermuda? You know, can they be stabilized enough, and do they have less injury to their other organs to be able to bring them safely for therapy? We always look at heart function. You know, is their heart function so bad that they need a transplant, or is there something that you can fix? Then hepatic function. This is a very major problem because if the liver doesn't work, then they often bleed. You know, how good are their kidneys? Our number one kind of complication after cardiac surgery bloodlessly is renal dysfunction. And so how do you protect the kidneys? The other thing that one has to deal with, and this is what I'm talking about in terms of their psychological component, intellectual component, is are there percutaneous alternatives? For instance, if we're going to do a bypass with somebody with moderate aortic stenosis, the guidelines always say you should take care of the aortic valve. It's a 1A, 1B indication. However, you have to make your judgment on, are you capable of doing an aortic valve and CABG on the patient, or should you just do the CABG and then do you follow it with a TAVR, which can be done percutaneously later on? So there are a lot of judgment involved, and this is where it is important to go to a surgeon who has the experience to take care of these patients. In terms of selection and preoperative preparation, stop anything that can increase bleeding, and specifically we're talking about things like Coumadin, Plavix, aspirin, and the supplements like fish oil, vitamin E, omega-3 fatty acids. We like to have our patients build up their hemoglobin. Iron is very important. There are many different types of iron. You just have to get something that's very bioavailable. One of our bloodless coordinators has found kind of a supplement that you can get on Amazon that seems to actually work very, very well in terms of building up people's iron stores. You have to replenish their B vitamins. And of course, Epigen is very important. If somebody has a low hemoglobin, we like to build them up to the 13 to 15 range, but honestly, very few of our patients actually get there. We can give Epigen at high doses. The problem in the United States is that Epigen is expensive, and a lot of insurance companies will not cover it if the hemoglobin is greater than 10. If they're in the hospital, we can give them mega doses of Epigen. And now we actually give them Epigen intraoperatively, and it's not necessarily to build up their hemoglobin, but there is a lot of studies that show that erythropoietin given intraoperatively can decrease the incidence of renal dysfunction, transfusions, and inflammation. And this is a great example of using bloodless experience in the blood patients, because right now, if anybody has an AKI who is bloodless or will accept blood, we will give them Epigen. So it is really it's a broadening of our experience in the bloodless patient population. We give our patients vitamin K. And the other thing that we do on the cardiac side is if they're on diuretics, we hold their diuretics for 2 or 3 days before their surgery to build up their blood volume. So when we do operate on them, we have some blood volume to work with. So then when it comes to the operation, and again, this is not only a technical exercise, it's also an intellectual exercise. You know, we say you have to have meticulous surgical technique, and I guess every surgeon thinks that they have meticulous surgical technique, but there are very, very subtle things in terms of how you hold the needle holder, how you rotate your needle, etc., that decreases the incidence of blood, from holes from needle holes, or bleeding from needle holes. At the University of Chicago, we have a very limited team of surgeons, of physician assistants, of anesthesiologists and perfusionists who actually do these operations. We don't really work a lot or allow our fellows to do these cases. These are not fellows cases. These are all attending cases. They do take a longer period of time to do. So when I do one of these cases, we don't have another case to follow. We only do one case in the OR in a day. They take about 50% longer because we're in the operating room making sure they don't bleed before they end up going to the ICU. On the top, you can see suture material. And this is what I always tell my fellows is that the #1 cause of bleeding is suture deficiency. What we do is as I'm operating, if there are particularly inaccessible sites, we'll do double layer of suturing. And we also will pressurize anything that we can to force bleeding to occur in the operating room so it won't bleed later on. So a lot of times people will pack or put pressure on needle holes that are bleeding, and we take the opposite approach. We actually make it bleed so we can fix it. And here's a picture of one of our cannulations. Normally, we just use suture for cannulation, but when we cannulate a Jehovah's Witness patient, we will actually use pledgets that you can see here. These are those white things that are pledgets. They bolster the aorta. So when we do put a cannula in place, there's absolutely no bleeding. Now that is, most surgeons will just put a purse string in, and if they bleed, it's not a huge deal. But for a Jehovah's Witness patient, it does become a big deal, because any bleeding that is extraneous, that is outside the vascular system, is a potential for loss. So the other thing is the sternum. Now, there's a lot of talk about doing these things minimally invasively, and what, in my experience, doing it minimally invasively also decreases the efficacy of an operation. So for instance, people will use smaller valves, they'll do fewer bypasses, they'll do a lot of shortcuts, and that hurts the patient long-term. So we do the right operation, we do a complete operation, and we do it via sternotomy. But when we do it via sternotomy for a Jehovah's Witness patient, here you can see us cauterizing the edges of the sternum. We use this special material called Hemosorb. And whereas in a normal, and then we do it twice, and we do it 3 times. So for a Jehovah's Witness patient, we will do the sternum 3 times, which is 2 times more than we do a normal patient. We then put pads around the sternum, then a towel around the pads, then we put in the retractor, and you will notice how bloodless that field is. That's a kind of an unusual field after doing a sternotomy, but every single one of our patients get multiple trials of the sternum, and we use the Hemosorb, where in a normal patient, we may use 1 stick. For a Jehovah's Witness patient, we use upwards of 3 sticks. Then when we close our sternum, we use titanium plates that we discovered at the University of Chicago about 24 years ago, and these plates decrease bleeding as well. Whenever we do a dissection, we use electrocautery because every single bleeder adds up. We really avoid any type of blunt dissection on these patients. And recently we've used this device called Aquamantis. When we do a re-op and we have bleeding coming from a diffuse surface, we use this Aquamantis to decrease bleeding. The other thing that we've discovered is that sponges and pads, and I used to say, just wring out the pads, but now we've taken it to the next level. And so for now, an entire cardiac operation, we will only use 1 lap, and we use 1 4x4. And what we do is we will take a bloodied lap, we wring it out, and then we'll take a cell saver and bring it out, and then we reprocess it. And at the end, so we reuse those lap pads over and over again. Normally, if they get soil, we just put in new laps. So for a normal case, we usually use about 20 lap pads and 20 sponges. And for a Jehovah's Witness patient, we've now brought that down to 1 lap, 1 sponge, continuously reused. So we dramatically decrease the amount of blood loss that's thrown out with these sponges. We also warm the patient up. This is not something we normally do, but for Jehovah's Witness patients, we get them up to 37 degrees and stay up there for at least 10 minutes before we come off pump, so they don't get cold in the ICU and then go ahead and have a coagulopathy. The other important component of it is to keep what you got. So our anesthesiologists know that they minimize volume on induction. Our perfusionists use a special circuit that has an ultra-low priming volume that uses 400 cc's or less than the conventional system. And you may say, well, why don't you use this all the time? The problem is that there's a sensor here that looks at the blood reservoir volume in the venous line. And if the blood goes below that, it continuously alarms. And that's a fixed sensor. You can't override it. And often in a Jehovah's Witness case, you think there's a symphony of alarms going off because they're always writing this blood just below that line. And that's why we don't normally use this, because it can drive somebody crazy if they come into the room. What we Our main method of stopping bleeding after surgery in terms of coagulopathy is that we drain the patient of their own blood, and that preserves their platelets and coagulation proteins. And what we do is we connect it to the venous reservoir of the cardiopulmonary bypass circuit. So this is blood, this is the patient's own blood before it's hit the bypass circuit and it's gotten damaged. And so this is fresh, warm, patient's own blood. It's connected to the bypass circuit, so it's validated by the Jehovah's Witness council members. And what we do is after the bypass run, after potamine, and there's absolutely no surgical bleeding, we then give this blood back to stop the bleeding. And we also use cell saver. But honestly, we try to avoid cell saver because we like to keep all the blood within the cardiopulmonary bypass circuit and give it back, and to avoid cell saver completely. In terms of postoperative management, our biggest issue is renal dysfunction, as I talked about in the past. So for that, this is where the intellectual component comes in. We start patients on renal dopamine or phenoldipan, and we keep them on till the creatinine crust in about postoperative day number 2 or 3. We use very large cannulas to maintain high cardiopulmonary bypass flow, and there's a concept called delivery of oxygen, and we like to keep it above 350. We avoid pressors after surgery. We minimize lab checks. So these patients, there is a set postoperative lab orders for bloodless patients and for blood patients. For bloodless patients, it is written that there's no labs to be checked unless clinically indicated. And so the amount of blood that we check for these patients is about 10% of what we do for other patients in general. That does require a lot more clinical judgment and a lot more intellectual work than just checking labs. But that's what we have to offer our patients. We give albumin for volume. We tend to keep them intubated after surgery until cardiac function and mental status are normalized. If there's any question, we do not extubate these patients because reintubation after an aspiration and ARDS can cause some problems. We start high-dose epigen and iron daily. And the other key thing is we accept low hemoglobins. Patients may come to us, and then after surgery, their hemoglobins go down to 6 or 7. Normal patients, we just jump on it and give them blood. For these patients, for the bloodless patients, we will just write it out and tell them they're going to be fatigued for a while, give them epigen and iron, and get it up slowly. So I'm going to give you an example of a very complicated patient. This was a 57-year-old who had a mechanical aortic valve 21 years ago and actually had some dilation of the sinus of Valsalva. And at that time, they did not take care of it because he was a Jehovah's Witness patient. They just put it in a valve. He had sudden onset of shortness of breath while exercising. He was on Coumadin. The first hospital thought he had pulmonary hypertension, and they didn't know why. So they sent him to the Brigham in Boston. You know, the Brigham recently advertises that they're a bloodless program, but this was too high risk for them. So he actually found his HLC, and they knew our HLC, so he ended up coming over to University of Chicago. So this was his problem. This is his MRI. You can see here, that's his mechanical valve. This is where the aorta should be, but his aorta was down here, and he had actually ruptured into the right atrium and into the right ventricle. He came to us in kidney failure, liver failure, and ARDS. And he came to us with no options. And so what we did, and this is, again, where his aorta was, as opposed to this is where his aorta should have been. And this had ruptured into his atrium. And you can see that on the echocardiogram there. And so because he was on Coumadin, he was coagulopathic, we try to temporize him. So this is, again, the intellectual component of cardiac surgery. We took him to the operating room, and on Christmas Day, our interventionalist put in what's kind of Amplatzer occluder device in this location. You can see it there, and it decreased the amount of shunt that he had across from his aorta to his atrium. Initially, his liver improved, his kidney improved, and then 3 weeks later, though he presented back with a recurrent leak, but by that time, his hemoglobin was better and his kidney and liver was better. And so we took him to the operating room, and you can see here, he's in cardiogenic shock with a very high CVP. There's that cribiform Amplatzer device that you can see here. There's the Amplatzer device. You can see that there's a significant leak. That's the yellow around it. It's a nice picture of the Amplatzer device, and that's his aorta. But again, this is the re-op that we did. There's his Amplatzer device. There's that aorta and the septum. And you can see here that the Amplatzer device is helped him, but didn't completely occlude what needed to be occluded. So the first thing we did was we took out this Amplatzer device. That's the Amplatzer device on the aortic side, and here's your aortic valve. And you can see by this time that Amplatzer actually migrated to cover the aortic valve. So here's what the Amplatzer looks like. That's the aortic wall right there. That's the sinus of Valsalva that is ruptured. And you can see the aortic valve on the other side. We pull this Amplatzer device out. You can see that's what we're about to do. There we go. So this is the Amplatzer device that we took out. There was the hole that was present that we then go ahead. There's the hole and there's the aorta. And this is the right atrium over here. So we go ahead, we repair this. We repair the hole. There's the tricuspid valve here. There's the hole right next to the tricuspid valve. This is the patch that we ended up putting in. There's his mechanical aortic valve. There's the patch here to close off that aortic sinus. And then this was the tricuspid valve, and we did a complex repair of the tricuspid valve. There's his tricuspid valve. We put a ring in there as well as repairing it on the side, and he's done well. So what are our results? So the advantage here is that Jehovah's Witnesses generally have a healthier lifestyle, and they don't have the bad influences of transfusion. And the other thing that's special is that they do have faith. And I think a faith goes a long, long way in how well they do. But we do have complications and deaths due to refusal of blood transfusions. And we can't kind of completely discount that. In our bloodless program, you know, we've done 35 heart transplants over the last 10 years and 10 last year alone. And a third of those have been reoperation of sternotomies. We've done LVADs as well, and we've done 11 last year. 1 year survival, very similar to non-JW patients. We've also done bypasses, valves, reoperations, dissections, aortic aneurysms. Our challenges are the distances that the patients need to travel to come here. A non-JW patient is about 32 miles of travel. A Jehovah's Witness patient is 10 times that. And of course, in the US, we have to deal with their insurances and travel to Chicago. So this is our map of all the states that have sent us Jehovah's Witness patients over the last couple of years. I think the biggest problem is that a lot of programs don't like to refer to us. They have egos, they have, you know, they don't want to show that they can't do a patient. So oftentimes the patients themselves have to refer themselves out of a network. This classically occurs with like the Cleveland Clinic or Mayo Clinic. And so a lot of our patients come to us with delayed referrals. So, you know, I implore to you, if you have a Jehovah's Witness patient, if you can't take care of them, please send them to us as soon as possible. Also, many programs just do enough to get away with a surviving patient who then gets into trouble. And what you really need to do is have a dedicated team like ours to do it right the first time. In between July of 2020 and January of 2023, we've done 139 patients with 4 mortalities. But these are very, very complex patients. And if you actually look at the observed to expected mortality ratio, it's less than half. It's about half. It's about 0.54. Realizing 1 is good, 0.54 is outstanding. So we do have mortalities. We accept that. But even with those mortalities, with the complexity of the cases we do, our expected mortality is half of what you would expect from a patient population that would accept blood. So we are able to provide this excellent care. And that excellent care then permeates throughout our entire program. And that is why we are the best heart transplant program in the country for both bloodless and non-bloodless patients. We have the best survival, the shortest wait time. We do the most bloodless, we do the most triple organ transplants, and we actually do the highest percentage of underserved minorities. So in summary, to develop a program, you need to have a dedicated and passionate team. And I have some people that I've put up here with whom our program just will not work. You have Maureen Wilson and Deanna Bassett. They're our dedicated bloodless coordinators. You have Calvin, Edie, and you have Allison, who are our cardiac surgery clinical team. And they work very, very hard working with insurance companies and physicians to get our patients here. And then once they're here, to show them love and show them compassion and believe in their faith and take care of them. We're also absolutely blessed with 3 fantastic HLC members, Guy, TJ, and Bernard, who relentlessly take care of patients. And if they are often referred patients from other HLCs and make their stay in Chicago viable, and they provide them spiritual support as well as logistic support in terms of being able to stay in Chicago. So with that team and meticulous surgical care, we're able to accept challenges, we're able to do complete procedures, we're able to anticipate the future. But we do have to be honest. I mean, there are mortalities that can occur. However, those mortalities are less than one would accept even if you accept blood. And we all have to respect their beliefs. And that, I think, is a very important component of what we bring, because our entire 4th floor is a dedicated heart hospital. And our patients are never asked, once they make a decision not to accept blood, no one goes and tries to change their mind. So with a lot of preparation, good fortune, and you can see our motto, which is on all our jackets, love all, serve all. The most complex cardiac surgery patients can be done in Jehovah's Witnesses, completely bloodless. And when we say completely bloodless, you know, we don't use red cells, whole blood, platelets, fresh flows in plasma. Matter of fact, we don't even use cryoprecipitate or Kcentra. We actually use very, very minimal. Most of our patients don't even use fractions, and we do that with excellent results. So thank you very much.